So folks, before I introduce and start officially, for those of you who don't know, it's David Rawson, President and founder of the Canadian Academy of Clinical Sleep Disorders Disciplines. Big word, CACSDD. Very simple rules like we've been employing in the last few meetings is everybody will be muted. We don't want interruptions, background noise, dogs barking, kids, TV. So you're all muted, and we'll leave it that way until at least question and answer period. Additionally, the questions have been handled more efficiently when you simply type them to me. So throughout the meeting, you'll find a chat box somewhere. I don't see mine right now, but there's a chat box where you can type your questions to me. I will ask them anonymously on your behalf in the order they come in. If that runs out and we have some time, we'll open the mics to verbal questions, but let's do it in the order that we announce it. So sit quietly for an hour, send me your written questions at any point. We'll take a little break at the end of the lecture and reconfigure for the question and answer period. And these will be available on two sites. We have our website up, fully loaded with all of the webinars till now, and they're also available on YouTube, and that's an open, non-private channel. I want to introduce the lady behind all this, Bianca, who's our Director of Communications, is a lady who's making all this wonderful stuff work. I'll take no credit for it, other than hiring her and saying, you're in charge, I'll take all the credit, you get all the blame. And so far, that's worked well. So Bianca, if you would like to just pop your face out so people can see who you are. This is the lady who's been in charge of all of the social media enhancements that we're been able to get going lately. We're reaching out to as many people as we can through other than email because it doesn't seem to work as well. So I'll just have Bianca wave her hand, and so people get to know who she is. You've probably talked to her already or with her. Oh, there she is. I've got participant screen in the way. So I think that's all I want to say, except tonight, another new feature. There have been some questions about CE and certificates of education. As you know, the world has changed since COVID. We're not quite sure what's going to happen, but taking attendance and keeping your attendance is important. So near the end of the lecture, just before we break for questions, there'll be a pop-up screen, an attendance poll where you're simply asked to answer a very simple question. I think it's how many seminars have you been? We'll have your information collected and we'll issue certificates for tonight, and any that you've been to in the past, we'll try and get caught up. But this is, it's a growing success story. Every month we have new challenges and new features to host. So without taking any more time from our speaker, those are the rules. We expect the lecture to be 50 to 60 minutes long, uninterrupted. No questions, please. All mics will be muted. So it's my pleasure to welcome back to our webinar stage and to a gentleman who spent 2 days with us, or was with us twice in Canada in our in-person meetings, Dr. Micah Sadigh, a PhD psychologist from Cedar Crest College in Pennsylvania, where unfortunately they got a bit of winter this year. They have more snow than we have in Canada. He's been teaching from home because he can't get out the door. His topic tonight is a psychodynamic exploration of the challenging patient. And we all have many of them. This is part one. Part two will be 2 weeks hence on the 24th of February, same time. Look for the announcements as we get closer to that. So welcome, Micah, back to Canada, even virtually, and it's all yours, my friend.
Thank you so much, Dr. Rawson, and good evening, David. Everyone. Good evening, everyone. It's a pleasure to be back here speaking with you. I am actually sitting in my office at the college where I teach, and I had a long class earlier today, and I was telling them about the fact that I will be talking to you tonight about a topic, and some of them actually wanted to join the conversation. So tonight I'm going to talk about a topic which I introduced you to 2 years ago, actually, October 2019. when I talked about personality dynamics. It was an overview type of lecture, and I know many of the participants, they were very gracious. They found it very helpful. They asked me many questions during the lecture and also afterwards. And I'm bringing back aspects of the lecture. This will be a brand new lecture in a sense than the one that I spoke with you about 2 years ago. This I'm going to focus on a specific cluster of personality disorders. And I hope you'll find this very helpful, and for reasons that I will explain to you in just a moment. I would like to start on a almost sad note, and the sad note being that as doctors in dental medicine, I honestly think that it was a wrong thing not to expose you to the study of personality in your education. I have given talks to dentists and physicians throughout the country, in the US. And each time I give one of these talks, it's amazing how doctors kind of discover that, oh my God, I almost burned out, or I got into trouble because I didn't understand these dynamics. So it's truly unfortunate. And I'm sorry you were not exposed to this earlier. So I am going to help you have an appreciation of how in dental medicine you're actually working with the unconscious mind much faster and much more readily than, let's say, a psychoanalyst sitting on a chair, a few meters away. So I'm using metric meters away from the patient. You're actually going deep into the unconscious almost immediately. And not understanding what those dynamics are about, how you're interacting with your patients in some subtle and unconscious ways, can at times make your treatment confusing, or as you will see, you may actually experience exhaustion, fatigue, or manifestation of all sorts of anxieties. I remember when I was a few years out of graduate school, I was still in my 20s. I consulted with a few dentists in this area, and they really liked my work. So I gave a presentation to the Pennsylvania Dental Association. And it was during that lecture that they approached me and they told me how they were coping with the things that I just mentioned to you, about their fatigue, about the anxieties they experience, unusual behaviors that they developed as a result of not knowing what was going on with their patients in their treatments. So, with all respect, and I mean this sincerely, dentistry is not about teeth and tissues. It's much more than that. And it's in sleep medicine, in dental medicine, you're not just working with appliances. You're working with a complex being in front of you who is interacting with the complexities inside of you, within you, with your personality. And at times, no matter how hard you work and no matter how much energy you put into figuring out the patient's needs, you may feel frustrated, emptied out, and which leads to a very real condition and very common among dentists, and which is burnout. And I hope down the road I'll get the opportunity of giving a lecture on burnout, which is a very real phenomenon. So if you're involved in educating dentists and you're involved in dental medicine in any way, my recommendation is add the study of personality and personality disorders to the curriculum, because that is so valuable and so incredibly important. I have a few questions for you. I just added these questions literally minutes before the lecture started, before I greeted Bianca and David. So I'm going to ask you to, if you don't mind, take notes, and I'm really looking forward to your questions. You're not supposed to ask me questions, and I understand that rule. But as a college professor, I count on constant interaction with my audience. So that's quite okay. We'll go by the rules. But if you don't mind jotting these down, do some patients drain you? And I mean, you work with a patient and you walk away. You may not be even quite aware of it, but it's 8 o'clock or 6 o'clock. Doesn't matter. You feel drained. Do you dread seeing some patients? You see a name on your calendar or your schedule, and that name suddenly, and you are a kind, wonderful, compassionate doctor, but it's just this sense of dread takes over. Are there patients that make you feel helpless, regardless of how hard you try to help them? I've tried everything possible, and I just cannot seem to be able to make a difference, and that is a very disturbing experience. Are there times when you feel like you're going out of your way to help a patient? It's just you're spending more time with them. I'm going to bring up this question again. That is a warning sign. That's a red flag. Please keep that in mind, and I'll discuss that with you in much more depth a little later. Are there patients that make you feel guilty, that after either during the time you're working with them or when they walk away, or later at night, you feel guilty? I did something wrong. I should have done it better. And then the last question I have for you, and I do want you to pay attention to it. So starting tomorrow, I do want you to keep these in mind. And this is where I've seen doctors ignore this. And when I mention it, they will say, oh my God, I had no idea this was the case. Are there patients that after seeing them, you feel sick? And just the question mark is missing. You mean literally you feel sick, sick to stomach, you have headaches, etc., etc. So keep these questions in mind. We've been studying personality disorders for quite some time. This goes back literally to the time of Hippocrates and then Galen. And then in recent years, this is a resurgence of some of the things we knew about and we were studying back in the 1940s, 50s, 60s, 70s, and then we became too overly technique-y and technique-oriented. So Hippocrates says it's more important to know what kind of a person has a disease than what kind of a disease the person has. So emphasizing the importance of personality, especially when it comes to chronic and complex conditions, because those complex conditions may not be simply a matter of structure, but a matter of function. And function is deeply affected by intrapsychic dynamics, things that are happening inside the person in their psyche, anxiety levels, fear of rejection, criticism, fear of abandonment, fear of or desire to injure you, to hurt you. Actually, that could be because you have become this parental authority person, and that the only way to get back at you is to somehow harm you. And as I will mention this again and again throughout this talk, these dynamics are unknown to the patient. Patients are not conscious of these, so please keep that in mind. In works of Galen about 1400, there were 4 types of personalities that were identified, again, from the idea that know the personality of your patient first before you jump in and treat them. So they had identified the sanguine personality. These terms are still around. I mean, in a silly way, by the way. Some people go to workshops, and this is incredibly dated. I'm just putting it up to show you a sense of history. But the sanguine personality was a cheerful one. Melancholy personality was the more sad type of personality. The choleric was somebody who was agitated and angry, and phlegmatic was someone who was fatigued and tired. And once you identified the personality, then then you would use the right type of treatment to match that personality. So in melancholy, let's say, they would use certain herbs that would thin out black bile and restore energy. Phlegmatic would be to thin out phlegm, use water, etc., etc. It's the beginning of really saying to us, your patient is not a device, it's not a machine, it's an incredibly complex being with a historical unconscious, where all kinds of experiences from early life to this point are affecting the way they interact with you. With you who's standing there looking at them, and you with your amazing chair over there, reclining them, which means you're regressing them and opening them up to all sorts of intra-psychic, within the psyche, sources of anxiety. So why do I need to know about personality disorders? First and foremost, and if we were to stop the lecture right now, I would say this is probably the most important thing it's for you. And I mean this, and I'm sincerely repeating this, but with great sincerity, that you should have been exposed to this a long time ago, and it's never too late. That understanding personality and personality disorders helps you to communicate with certain patients. And as you will see tonight, your statement that may even suggest a tiny bit of criticism will put an end to your relationship with certain patients, just tiny bit. So I see you haven't been wearing this appliance properly. You're smiling, you're playful, bantering, very kind, gentle, but the fact that it suggests that I did something wrong from the patient's perspective means I'm being criticized, I'm bleeding. That's the end of me, or I'm not going to expose myself to this kind of harm. There was no harm. You recorded the lecture, played back every word you said, but notice that it's the patient who is hearing you in a certain way. You're the authority, at times you're a parent. To increase empathy, so that's extremely important. And then I will give you the definition of empathy. Empathy is to see the world through the eyes of the other person. And there's nothing more important, more beautiful than that, to just for a moment to suspend your perception, and to see the world through the eyes of the other person. So once you have an understanding of personality disorder, you know that when you're standing there with certain personality, you become godlike. You are some divine, omnipotent, all-powerful being that I am just completely submitting myself to. And that's a specific personality that places you in that role. And you say, I'm not God, I'm not some deity, I'm a doctor. It doesn't matter. So the fact that they see you in that fashion, what can you do? Yell at them, get upset with them? No. It's to help them see you as who you are down the road. Your diagnostic process will improve. So that we've tried to do this, we have made these adjustments. The jaw is moved, and teeth are in the right place, and we've done all the but there's some kind of resistance, or there's some sort of anxiety that comes up. Again, an understanding of personality will assist you in that. It also helps you not to get distracted so easily, because when they throw all kinds of distractions at you, understanding what those distractions are about helps you to go back and focus on what's happening. Because patients with certain personality disorders can pretty much use up that entire session totally unrelated to what you're doing, and if you figure out how to bring back the attention to the purpose of that meeting, things will work much better. Just kind of mention that in histrionic personality disorder, which I will not be talking about this time, you will spend an hour, 2 hours, and not accomplishing much. And finally, why should you know about personality disorders? Because your field has a very high rate of burnout. In fact, in any clinical field, we see burnout, and there's data coming up from time to time. This is slightly dated, but this was one of the first studies I saw on burnout, and this was when I was a doctoral student, and it had to do with they were looking at rate of suicide in different professions, and dentists were on top of the list. And as you know, since the advent of COVID-19, the number of suicides among healthcare providers has jumped up. A dear friend who's a dentist and practicing dental medicine, we had a conversation years ago, and he said to me, you know, I never thought about until we had this conversation, never thought about it, that you know, sometimes you feel very helpless in this field. And I said, because most of the time, very close, your face very close to the face of the patient, what you see is not smile or sense of pleasure. You see pain, you see anxiety, you see apprehension. Even if you have done the most beautiful dental work, as magnificent as it may be, they will not appreciate your work until when they get home or days later when the swelling is gone or when the appliance is working, et cetera, et cetera. You don't necessarily get immediate positive feedback. And some do, especially when they come back for a meeting. So burnout, please note, is a very real thing. And it's devastating what it will do. Either you'll develop maladaptive behaviors to cope with the burnout, or I've seen this, which is unbelievably tragic when very talented, gifted physicians, dentists leave their practice. That's it. I have nothing to do with it. That's burnout. And sometimes burnout also leads to self-destruction. All right. So have I convinced you at this point why it's important for you to know about personality disorders? So tell me later, but I hope the answer is yes. And if you want me to add to those 5 that previous list, I'll gladly do it. So once again, as I mentioned before, the personality tendencies that we will be talking about during these lectures are not known to your patient. This is not something that you can and you should not even make an attempt to do this by saying to your patient, you know what, you're suffering from some dependency issues, etc. That will mean nothing to them. In fact, they may feel injured by this terminology. So please don't think that they're sitting there kind of throwing some complexities at you to just torment you. These are unconscious, deeply embedded. Many of them are formed very early in life. And they're affecting not just your relationship with your patients, but they're affecting the relationship with their significant other, their children, co-workers, etc. So please keep that in mind. They're not consciously trying to torment you or hurt you. These are good people who are suffering, basically. There's a deep pathology at work, which causes them difficulties in life. So let's take a look at a couple of definitions of personality disorders, that is. And I would say if there's one word I will hold on to, if there's one word I do want you to remember, is that they've become inflexible. What would be a synonym for inflexible? They've become rigid. They have to go through life in a specific way. And if you push them out of that specific mode of functioning, that causes them a great deal of anxiety, apprehension, or they may actually become aggressive toward you. So it's an inflexible and it's maladaptive. And maladaptive comes from Latin malum, evil. Maladaptive doesn't mean evil. Maladaptive means adapting in a way that is actually doing more harm than good. That's really what maladaptive means. Maladaptive behaviors are behaviors that initially work and work quite effectively, but in the long run, they do more damage than they do good. I'm very anxious, have a drink. Oh, wow, I feel so much better. Next time I'm anxious, I'm going to have a drink. Next time you are completely dependent on alcohol, that is maladaptive behavior. So in personality disorders, these are inflexible, maladaptive behaviors, such as becoming incredibly dependent, feeling that the person is going to fall apart and just be annihilated if you don't show up for an appointment or you cancel their appointment, etc. It's maladaptive pattern of relating to self and others, to oneself and others. The way, so it's not just the way they treat others, but also the way they treat themselves, which causes impairment in functioning, and it causes a great deal of distress. In other words, people with personality disorders experience a great deal of distress, and also some of the tasks that they're engaged in are often impaired. They don't complete them properly. DSM-5, this is the latest edition of the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, defines a personality disorder as an enduring, so it lasting, it doesn't come and go. Enduring an inflexible pattern of thinking about oneself and others, feeling, behaving that sticks around. It's an inflexible way of dealing with the world, basically, and oneself, as I mentioned. The DSM offers 3 clusters of personality disorders. And when I was with you in your beautiful country back in 2019, I spent some time talking about at least 3 of the disorders in cluster B because some of you wonderful doctors had asked me to discuss them. So, and I kind of very briefly mentioned cluster A and cluster C. Tonight, I'm going to specifically talk about cluster C, and specifically about avoidant and dependent. I will not be able to cover obsessive compulsive personality disorder in tonight's lecture. I don't think we'll have time to do that. So I will spend more time with avoidant and dependent personality disorders. You need to be familiar with all of these. And tonight's lecture, I had to choose one, and so I've chosen one that it's more likely that you're seeing people in this cluster than the other cluster. More likely, you're probably seeing people in all clusters, but more likely that you're seeing them in this cluster. And this cluster, based on research that has appeared in the literature for years, actually, when you think of it, once you understand it, it's much easier to treat this cluster than the other clusters. So it's, if you understand their dynamics, it's actually, and I'll show you how to work around the dynamics of these personalities. So cluster A are, you very rarely see these in your practice, and if you do, they're very unusual presentation, the way they appear, the way they show up, the way they engage you. They're odd and eccentric in their presentation. Will include paranoid, schizoid, and schizotypal personality disorders, ranging from intense suspiciousness of what's in that, or why did you close that? Are you recording the session? Why did your nurse leave and she brought something back, etc., to being very detached, almost robotic, having no expression of feelings, etc. In the schizoid, and schizotypal being unbelievably irrational and saying things to you that simply don't make sense, and there's something bizarre about their presentation. Wonderful, they're highly creative people, but their presentation is very unusual. Cluster B is when you will see, so odd eccentric versus cluster B, which is intense dramatic presentation. There's emotionality, there could be rage, anger, tears, but exaggerated, very intense, very troubling at times, or intense desire to befriend you and to be your buddy, and checking your tire out in the parking lot and noticing that you're, I kid you not, this was actually a real case, that you don't have enough air in your tire, and wanting to be your buddy and walking with you and calling you doc and buddying you, so that they can potentially get something out of you, a prescription for medication, etc. So that would be the antisocial. Borderline is you're God today and you're the devil the next day, just intense. And this is probably the personality disorder, I would say, that requires and needs the most compassion, because the torment that people with this disorder that go through is tremendous, and it's tremendous. I honestly, all of these, the first step should be compassion. It's not to label them or dismiss them, but to understand that they're actually hurting inside. Histrionic is, there's a level of inauthenticity, the way that they speak to you, the way they cling to you at times, the way they make sure everybody in the room and the next room is hearing them, etc. It's some kind of level of inauthenticity. And then a personality that feels very much superior to you or anyone. And I've seen many doctors here and there. So the fact that I'm seeing you, you must feel privileged. That's the message they're trying to give you, that I'm actually giving you the opportunity to look inside my mouth. That's what the narcissist. The C cluster, cluster C, would be, these are highly anxious individuals. They at some level, they're living in fear. There's a fear of something bad is going to happen, and they have developed defenses to reduce the fear and the anxiety that they're constantly, at some level, they're grappling with it. Some become incredibly rigid and pay attention to details to great extent. That kind of attention to where is everything, how many tiles, etc., prevents them from really dealing with the anxiety that they're experiencing inside. Some appear to be tuning you out. They're in some sort of a fantasy land somewhere. The thing is, if I come out of that fantasy, if I really expose myself to, you're going to injure. That would be the avoidant. And the dependent is, without you, doctor, I will be annihilated. I will die. And it sounds illogical and irrational, but no, that's how they see it, that you have become actually a center to their existence. One way of thinking about cluster A is like there's some disconnect going on. They don't connect to the unusual. There's something very unusual about who they are. Cluster B, everything in life is about me. So take care of me, be good to me, pay attention to me, listen to me, take care of me, and don't leave me. And cluster C, I'm expecting that something bad is going to happen. Let me tell you what we're going to do next week. What, you're leaving? You're leaving your practice? Where did you get that idea from? That would be the dependent, anticipating and expecting something bad like that to happen. I'm going to quickly go over these. We'll be talking about dependent personality disorders. So difficulty making decisions. This is a person, could be a lovely person, an adult person, beautifully dressed, very kind, very compassionate, very loving, articulate, but in a sense, at some level, they're very much a child that require a parent to take care of them. Tell me what to do. I will not let you down. I will follow you, even if you, in some way, shape, or form, if you contradict yourself, they will go with your contradictions. They do not want to be alone. They cannot be alone. Being alone means, again, a sense of that something bad is going to happen. fear of being left alone, left to take care of others. I'm sorry, that 8 for some reason shows up to. So they really want you to take care of them. They want you to parent them. This is the avoidant personality disorder. So if you are taking notes, it's extremely important that you please pay attention to this. Oftentimes, and this is such a wrong thing to do, people refer to these as antisocial, which is not what they are at all. Antisocial means being against moral rules, ethical rules of the society. Avoidant personality are avoiding relationships because, I'm going to highlight this here, because they're preoccupied with being criticized. They're afraid that sooner or later you're going to criticize them. So intensely sensitive to being criticized. They think of themselves as socially inept. And if you get to know them, and I've had the great pleasure of getting to know some people who had this disorder, they are rich. They're rich with fantasy. They're unbelievably observant. They have an incredible sense of the need for affection, being close to people, and in their fantasies, which are incredibly detailed. They can become magnificent writers if somebody could move them in that. Detailed about being taking care of animals and why are animals so important? Because they don't criticize you, do not put you down. The obsessive compulsive, which I will probably talk about next time, are preoccupied with details. They are perfectionistic. They will criticize you. Forget about being critical. They will criticize you. You're late 15 seconds. You didn't do this right, etc., etc. They're very conscientious. They are very tight in terms of how they spend things, regulate things. They can be very, very stubborn. And if you push them out of that structure that I've created, you will see intense anxiety. So if you want to help these people, give them structure, and they will follow structure. So remember one word, structure. They like structure. So if you say, I want you to do a couple of things. No, say, I want you to do A, B, C, D. They're at home with you. They will enjoy being with you. Begin with the dependent personality disorder, also called the oral character. And this should get your attention. You work with the mouth. You are dealing with one of the first stages of development, personality development, clearly from a psychoanalytic perspective, and also in its more modern manifestations. But that early part of that dependency goes back to early parts of life. And so very early in the life of an infant, the child is fed, the parents interact with her, with him. Child makes sounds, there's spit a little bit, and they get attention, etc. But to survive, the child has to submit herself or himself to mom or others, so to be fed. Now, if they get stuck in this, fixated in this stage, they become needy. I can't provide myself, it must come from the outside. So there's a receptivity, this need for receptivity. Just everything good comes from the outside. And then a little later, oftentimes this part is skipped. They begin to teeth. So that teething part also gives them the capability to bite and to say, you were late. You didn't pay attention to me. And I hope adults don't go around biting people, but they do bite you. And I'll tell you how. It's called sarcasm. And if you look at the Greek origin of that word, it literally means to bite. So they can actually be very receptive to you. In the middle of a session, at one point in the session, they may bite you, they may criticize you, they may get angry with you, and in a way attack you, to put you down, etc. A term that was erroneously introduced a long time ago. There's a passive-aggressive quality about it. That aggressive quality may also not show up in a session. It may show up where they criticize you or put you down, while at the same time they are depending on you. They go out behind your back and they do something to injure you or harm you because you didn't pay attention to me. You didn't give me what I wanted. You didn't give me the reassurance that I needed. That's the oral statistic. The features of the dependent personality disorder, one of the key features is that you are in charge of my life. You tell me what you do, and I'll do it. So it's not just what's happening in your office, but it's also at home. It's also at work. They're putting themselves down, making themselves vulnerable, so that they will get the attention and comfort from others. So I question my ability to assume responsibility for myself. Please make a note, under stress, when the person is under stress, such as when they're in pain, such as COVID-19, such as when there's struggles in relationship, you will see an intensification of these symptoms. So stress, uncertainty in life, etc., will add to these. And to me, one of the worst stressors, I don't think there's anything that comes even close to this, is pain. Because I can walk away from a relationship for an hour, I can go for a walk, I can avoid a colleague, etc., but I can't walk away from my own pain. So pain could be forcing them in this direction. They lack self-confidence, and this may agitate you or often. You know how to do it. Come on, do it yourself. No, I don't know how to do it. Go ahead, put it in your mouth. Move it around. That's okay. You won't hurt yourself. No, I can't do it. I can't do it myself. Deep down, they have a fear of separation. They're afraid that you're going to abandon them. That's something that we really should talk about a little later. So that anxiety of being abandoned and that separation anxiety, it really has to do with much earlier stage of life. So it's something that has not been resolved. Just important to note this, sometimes when people have undergone severe surgeries, very deep, very complex surgeries, or they have suffered from medical conditions that have disabled them to some degree, you may see manifestations of dependency because they have been injured or some damage has been done to them. So that's when a medical condition takes you back to more earlier stages of life. That actually could happen as well. Oftentimes it's the other way. It's the other way, that is, the personality disorder will contribute to the manifestation of different medical conditions. That's it. So please remember to have a fear of abandonment, and they will do anything to make sure that you're not going to abandon them. Depressive features are very common in these individuals, in addition to anxiety, and they can't adjust. So please make a note: new situations are difficult to cope with. So anytime you see change, here everything was going well, but they moved to a new home, or there was a change in job, and all of a sudden your appliance is not working, or your dentistry, or what you're doing, wonderful work that you're doing, all of a sudden has lost its effectiveness. And the appliance is too high over here, too low over here. Where did it come? So they can't adjust. Because they can't adjust to the situation out there, you're going to manifest all sorts of symptoms that could be physical. That's it. When you're talking to them, they tend to put themselves down. Oh, everybody knows how to do. Oh, no, I'm dumb. I'm dumb, doctor. I'm not good at doing that. I've said enough about fear of rejection. They will agree with you, whatever you say. drink some cold water with hot water. That will do it. I don't know how they would do it, but they will. They're very gullible. They'll accept anything. So I think the internet is a dangerous thing for people with this disorder to be exposed to, because whatever they read on the internet, you're going to believe it. There's no critical thinking. History of psychosomatic symptoms and disorders, which I wish I had a couple hours to actually tell you about this. It's the turning their anxieties into physical symptoms. So please note, you never ever want to say to them that we want you to become independent, so that you can, even if your intent is a positive one, is a healthy one, just put in, do not use the word or suggest anything that suggests independence. Independence means you're a baby and we're going to put you outside. Means death. Means, because at some level there is this baby that I can't function without you feeding me. So medical symptoms means I need a doctor, and particularly when it comes to digestive problems, which also kind of promotes a level of regression, going back to earlier part of life. You are an authority. You are an authority, and at times, in subtle ways, as I mentioned, they may punish you because you were late, because you didn't spend as much time with them. One thing you will discover, I'm kind of laughing because there's something kind of amusing to me about this, is that you're not the only doctor, and at times you may discover that in another town where it's unlikely you know this doctor, in this, they may have another dentist over there or a physician in another town. Just have a backup, just in case one of you leaves me. I have a backup. You're a godlike being, as I said. They somatize, which means they turn their anxieties into physical symptoms. And this has a variety of manifestations. To me, one of the major manifestations of anxiety dependent personality disorder has to do with the development of gastrointestinal symptoms. And you'll say, well, I don't have anything to do with that. But yes, you do. Yes, you do. You are the beginning of the digestive tract, the beginning of the digestive tract. Of course, you're playing a role in their lives. So gastrointestinal symptoms and symptomology take you back to the early part of life. We call it case where a person was developing all sorts of bowel problems, or multiple surgeries, etc. And with each surgery, she was becoming more dependent, and she was becoming more childlike. And they would go and look around and remove something over here. We didn't see anything wrong, but let's do a little surgery and cut something up. It was ultimately about, let me become more childlike. Please note, these are not conscious events. Numbness, and particularly numbness and pain in legs and feet where they can't ambulate. Again, you have to help them out. So these are severe manifestations of this disorder. Probably the most fascinating case of a conversion disorder that I was ever asked to do a consult with regard to this case, just a few miles down that way, at the hospital, was a case of a gentleman who had a wonderful surgeon, amazing, wonderful, capable surgeon who had done a C3, C4 fusion. And this patient was in a lot of pain, had been there going through physical therapy for years and years and years. And they finally do this surgery, very successful surgery. And doctor, in a positive tone and a hopeful tone, congratulatory tone, says to the patient, and the doctor couldn't actually remember this, so I had to kind of reconstruct it, says, and you won't need us anymore. You won't need us anymore. The patient goes, stands by the door, opens the door, and collapses, paralyzed from waist down. And they did all kinds of MRIs looking for, where their nerve was being impinged, etc. It wasn't. It was a functional neurologic disorder, which is the new term for conversion, so converting anxiety into physical symptoms. And we found ways of, so it's functional, it's not structural. You become their center, please note. So there should be a warning when you're going through your education. Once you become their center, they will need you to hold them together. You become their center without knowing it, and unsuspectedly, you become the center of their lives. All right. These are some of the signs that I'd like you to observe in yourself. Please observe these signs in yourself very, very carefully. Are there patients that you spend more time than you can afford, more time with than you can afford? Just you have 30 minutes and you're spending an hour with them, and the next patient you're going to be late, etc., etc. Ask yourself, what is it? Why is it that I'm spending more time with some patients? Some patients may need it, but this is consistent. You are suffering as a result of that. I just want you to know, and you need to protect yourself. Patient leaves, and you find yourself sad about these patients. You feel helpless at times. You're preoccupied. I want to take away. If I would just do this way, and if we would just come up with a new appliance and just raise this just about a millimeter and just decrease it. I know there's a way I can solve this problem. You're overly protective of them, and you get lots of phone calls from them. Or, I don't know how to do this, and they're very basic. They may frustrate you, anger you at times, because that's just I explained to you. You have to use the brush in this way. It's something simple, but they ask you to repeat it. You're working with these patients, and in subtle ways they criticize your colleague, or you send them to Dr. So-and-so in another town for a consult, and they will say something, oh, Dr. So-and-so was so nice, but not as nice as you. And that injection was really hurt. The way you inject is so much nicer. So I guess they don't know what subtle ways of, injuring you or the colleague. That's the biting. And as far as your office staff is concerned, you'll notice that please note this and please protect your office staff. Your office staff, these are patients that your office staff, they go out of their way to take care of them, bring them water, make sure they're, which is lovely and very kind, but they have become a part of the family, so they're taking care of them, being extra nice to them, etc., because of that vulnerability, that childlike type of a manifestation. So this is a quick case. You'll have my slides as soon as I'm done here. This is a gentleman who has jaw pain. I'm kind of combining various cases. There is no such person. I'm kind of combining features of a number of patients. Jaw pain, headaches, poor sleep, GI disorders. Please keep that in mind. Should I ask about GI disorders? I just mentioned that to you. Yes, you are an important part of that digestive tract. I was doing a consult with two dear friends, a dentist and a pain specialist, and they were talking about a patient who had all sorts of, was gaining weight, and he had jaw pain and couldn't open his mouth, and it was simple. I can't open his mouth, but he's gaining weight, incredible amounts of weight, to obese and has all kinds of digestive issues. Where do they come from? It's anxiety. It's tremendous anxiety. He's been hospitalized. He has all sorts of symptoms here and there. He he does not sleep well. And when you help this person and you make adjustments, let's say again in an appliance, you give them a device to help them with their sleep setup. It works briefly, maybe for a few days. Definitely during the session, it's like, thank you, doctor. Oh my God, that feels so good. And then they come back and it didn't work or something is wrong with it. And at one point they blame themselves. It's not your fault, doctor. I'm a loser. I'm bad, etc., etc. Help me, help me. And also this person arrives early to mingle with the office staff. So what can you do for these person? Please remember these things. So these are the, I will make like little cheat sheets. I'm going to page through these. Work on smaller goals than larger goals. So create smaller than larger. Not to fix this, but let's see if we can just improve tension over here. Just help you sleep a little more over there. Do not enable them. Do not say, I will take care of you is enabling. Let's work on this is empowering. And it's very important that you say, let us work on this. We're here together. We're a team. Repeating that. That's that would be it. Give them active guidance. Show them, put your finger over here. Yeah, very good. Oh my God, you held it much better than you're going to give them active guidance. Don't speak to them in abstraction. Note, you want to stay away from independence, but working together, empowering them bit by bit. Show them if you have a dummy appliance that you can't put in your mouth, and kind of show how it's put, and then have them put it in. So you're working together. Mom and dad, mom and mom and child, dad and child. It's almost like let's do it together. This is how we do it. Please be patient with them. They will improve. They will in time improve, and they become less dependent on you. But it's a very slow curve. It's a very slow slope going up before it flattens. Yes, initially you have to hold their hands, and if you don't want them to constantly call you and demand your energy, you need to give them what's called transitional objects. These are reminders of you. These are reminders of you. And I have taught many physicians, I've taught many doctors to use transitional objects. And the transitional object could be, I know they're becoming very passe at this point, but I highly recommend you keep a couple of cards at your desk. Instead of your wonderful administrative assistant doing these, I want you to give them a card and write a note like, I want you to do the following, or you don't have to, I will see you next week. And one doctor that her patient was actually driving her absolutely mad. She said, I said, give a transitional object. And she said, the patient said, oh, I was going to call you last night, called your answering service. And I picked up the card, and in the back of the card you wrote, I'll see you next week. And I said, oh, I can't wait until next week. So you're with me, transitional object. Until you're interjected a part of me, I have a reminder that you're there. There's you out, not just a fantasy. This is the formula. Small, achievable goals. Not just goals, not just achievable goals, but small achievable goals, and remind them, let's do this together, one step at a time. Finishing this section with discharging them. When you're frustrated, when you've had it enough, you're tired, inspiration has been coming for so long, etc. But discharging without proper planning may contribute to suicidal ideations. I have a paper actually somewhere on my desk. Actually, I even have it here. It's on dependent personality disorder, critical review, where you see that when they feel rejected or abandoned, suicide becomes an option unless you connect with someone else. It's after 8:30. I apologize. I did not get to avoidant personality, so I'll leave avoidant personality and compulsive obsessive compulsive personality disorder for our next meeting. So thank you for paying attention. I'd love to hear. Well, Dr. David is going to read your questions soon. I want you to think about yourself. I want you to think about how you respond to these types of personality. What are the adaptive and maladaptive behaviors that you have acquired to deal with these things? How do you cope with these things? How do you cope with these types of situations? And some of them are adaptive, some of them are maladaptive. I think you need to understand the dynamics of your interactions with these patients. So I am going.
Thank you, Dr. Sadigh.